We might as well get started. I know there's not 380 of you here right now. There's the town hall going on in 401, and I think a lot of students will stay over there. And but I think to respect all of you who came here and want to hear Dr. Powell speak, let's get started. So I'm just going to give you a short little intro to what we're doing this month. Just to remind you, so the P&S students understand what Foundations of Clinical Medicine is. It's part of their multi-semester non-direct patient care, more the sort of what medicine is, and with some activities in clinical care. And then the SLIM component of it stands for Systems, Leadership, Integration, and Management. When Dr. Powell speaks, you'll sort of you'll get that it's a play on words. In Toyota, they use a term called lean, and Dr. Weil up at Bassett coined slim lean. Very, very nice. So we put together. We're actually in our third year now of the SLIM curriculum at P&S, and we really had some pretty simple goal. So the unique new course for all P&S graduates to be able to become health system transformation agents. A graduate would be able to transform the healthcare system. And our mission statement is that you'd have this background knowledge, you could solve problems, and then probably more importantly, embrace that responsibility to do that. So that's a major thing. Like not just did you get the skills, but you're really going to feel that you're personally responsible to do that. So what I did, so how fast things can change, because we've invited the School of Nursing to participate. It's a major milestone for us. So I just changed it. So this is now SLIM at CUMC. See that? See how easy that is through the power of the wizardry of PowerPoint? So, I mean, I'm getting a little ahead of ourselves here, all CUMC graduates. But at the end of the day, I mean, we could be this ambitious. Because it's going to take all of us. This is not something for physicians. It's not something for nurses. It's not something for OT and PT and public health. It's something that we're all going to do together. So having School of Nursing join us, which we're so happy to welcome you, gets us on that road to SLIM at CUMC. So this is our schedule. I just want to go through it kind of a little quickly here. Today we're talking about Virginia Mason Production System. In week 2, we're going to have 2 panels, and you've been assigned, one into 2 different rooms, because Dr. Bollinger, the president of the university, is going to be speaking here, conflicting with us using this room. So we're going to be in AMP1 and 401, and we're going to actually have providers come and talk about their experiences and how they got there and what their education was. And it's going to prepare you for the small group multidisciplinary rounds. And because there's so many of us, though we're not all here today, we had to divide everyone up, and we're going to have 2 workshops. So you're either in Group A or Group B. You're either doing the multidisciplinary rounds simulation, or you're going to be working on, my pet peeve, and you'll get a little more detail about that assignment in the next couple of days. And then the next week, I'm going to give a lecture on how do you do process improvement, and then we're going to flip the groups. So that's the 3rd week. We've already started getting some emails. If we assigned you to a group and for whatever reason you can't come, the highest priority is that you participate in the multidisciplinary rounds exercises, because that's where I think you're going to learn the most for your future. So we've asked that you either find someone to swap with or contact us, and we'll figure out and rebalance the teams. The 4th week, we're going to be talking an approach to multidisciplinary rounds. So you'll have your second case, and then we're going to bring in folks from NYP who you'll be able to learn from and what are they doing in their quality improvement projects. And then in the 5th week, we flip the groups. So that's the 5 sessions. I think you'll be entertained. I think you'll learn a lot. And it was a good experience last year. We had 24 nurses join us last year, and I think we all gained a lot from it. So what are we trying to do? Why are we mixing the 2 schools? Well, it basically goes back to 2003. The Institute of Medicine, they came out with a report called The Bridge to Quality, and they basically identified patient-centered care where an interdisciplinary team education approach was critical. So that's a long time ago. We haven't made a lot of progress. And what they call IPE is 2 more professionals learn with, from, and about each other. So this, and you really have to start from the beginning, not like 20 years into your career, now you sort of learn about each other. And then in 2011, there was an interprofessional education collaborative, And what they talk about is, values, roles, responsibilities, communications, teams, and teamwork. And, we're going to accomplish that in these sessions. So this is our first attempt at this. Last year, we had 24 nursing students joined us as a pilot. It was a good experience. This year, we've invited all 220 school and nursing students from your part of your curriculum. And this is really the first ever large-scale IPE event at CUMC. So it's a little bit of an experiment. Just so you know, this stuff's not easy. And there's scheduling issues, there's logistics, there's rooms, there's preferences, there's time of day. We typically have the Foundations of Clinical Medicine classes much earlier in the day. So we've asked, because of the School of Nursing students' day, you were only available at 4. We had to move everything around. So just logistics like that, and then finding faculty who want to stay between 5 and 6. So we want to grow this. Next year, we would love to have physical therapy, occupational therapy, College of Dental Medicine, social work. This could grow rather large, and it is necessary. So, today's guest lecturer, Lauren Powell. She received her MD degree, MBA. This is a major milestone in our program. She was in the first group of medical students who took a course that I've been teaching for a bunch of years on how to redesign systems in complex organizations. She got very excited by that course. She went on, got her MBA. She took so it's a 5-year medical school curriculum because she did a year down at the Columbia Business School. She was a founding member of the SLIM Student Committee, which sort of drives our curriculum. It's a very student-oriented curriculum. We update it regularly based on feedback that we get from students. She then graduated in 2014 and went out to do her internal medicine residency at Virginia Mason Medical Center in Seattle, Washington. And in her own words, she's highly interested in systems improvement, and she's a product of our program. And I'm very excited that she's here today to, like, where have we gone with SLIM, and what has she learned in Seattle? So I hand it over to her.
So I've never used one of these before, and apparently I didn't wear appropriate clothing because it's meant to be attached to pants. So if this falls off at any time, you can just feel free to just laugh and we'll move on. But I'm really glad that you guys showed up and came here today. I know that there were kind of other things going on, so I really appreciate you guys all being here, and I hope that I can add something of value and hopefully tell you a little bit about some of the improvement work that I've been involved in and have witnessed at Virginia Mason. And Dr. Sedeli asked me to talk a little bit about, first before we start, about how I even got interested in process improvement. I'll just spend a really small time on that. I read about Virginia Mason when I was my last semester in college in a healthcare management class, and kind of changed my career path since then. I found it really exciting to think about how you could apply concepts from other areas of business and apply them to healthcare, and really try to improve how things work and how we deliver care to our patients, which is why we're all here. So led me to get the MBA and then eventually to go to Virginia Mason for my residency program. It's been a great experience so far. But first, before we start, you might be thinking, what the heck is Virginia Mason, and is it in Virginia, and why should I care? So we're a healthcare delivery system located in downtown Seattle. It's about a 300-bed hospital. Pretty small compared to NYP, which is, I think, about over 1,000 beds. So just to give you some sense of scale there, we've got a full range of outpatient services too, so primary care and also specialty clinics kind of integrated in the same system, same EMR, and we've got a bunch of outlying clinics in the surrounding areas. We do get a lot of transfers or tertiary referral centers, so we do get a lot of transfers of complex patients from other areas and Washington State and Alaska and kind of the surrounding areas. And then we do have a bunch of residency programs, actually. We have medicine, surgery, anesthesia, and radiology. And be committed to becoming a leader in healthcare quality, which is what I'm going to try to talk about today. So before I start any presentation talking about Virginia Mason, I just start with the pyramid. We lovingly refer to it as the pyramid. And this little, we kind of make fun of the fact that we always start with this, but this is our strategic plan. And most people who work at Virginia Mason can't tell you any of the stuff that's in the middle there. But the important part is what's at the top. That's the patient. And this seems a little cheesy, but we always like to start out our presentation to remind us why we're here and why we're doing the work that we're doing. And we want to make sure that all the work we do to improve the quality of our care, the delivery of our care, we're thinking about the patient as the top priority. All right, so this is just a sense of where we're going. I'm going to give you a little introduction on what is the Virginia Mason Production System. We're going to do a brief case study in primary care, which is my area of interest. I'm going to talk about a little bit about improving nursing care, and then our quality improvement curriculum and some of the ideas I've seen my residents put into action. So before we start out, how many of you guys have ever been frustrated by something that you've encountered? Show of hands. Maybe it's, anyone want to shout anything out? Getting through the airport? Security lines, maybe? Or too many emails. Yeah, I think everyone can relate to that one, right? You're bombarded, you get 12 emails a day from your program, and you don't know what's important, what's not important. Maybe you guys haven't been to the hospital yet, but if you want to try to find anything in the supply closets, it's almost impossible. That was one of my pet peeves. What would you do? What if you had an idea? What would you do with that? Do you know who you would talk to? Do you even know who you would go to? How would you test it? If it worked, how would you implement it across an organization? If you had no process with which to capture ideas, to turn them into something, would you keep having them? Would you tell anyone? Or would you just keep your head down, get your work done, try to go home? Well, I want you to imagine, you may see where I'm going with this, but what if you had a system with which to turn these great ideas that you had into action? If you were empowered not only to share them, but to test them and implement them. If you had the tools, if you're taught the tools and you had the methods available to help you improve your work, and what if quality improvement was expected to be part of your work rather than something you do outside of it? Oh, that's just a pet project. We're working on that in my spare time. What if it was part of the everyday work that you do? So you may see where I'm going with this. We're going to talk about the Virginia Mason Production System, which is such a system. It's something we've developed from Toyota, and it seeks to continually improve how we do our work. You may have also heard this called Lean. It's the same thing. We apply concepts that were originally developed for manufacturing to try to identify waste and eliminate inefficiencies in healthcare processes. And the way that we do this is by empowering frontline staff, including all of you, to prevent errors and eliminate waste in patient care. And to me, this is the most powerful part. Most management structures, traditional management structures, are top-down, meaning that your boss tells you what to do, you do it. They tell you how to do your work, how to improve your work. This is a different strategy. This says, you're the one doing your work. You know how the work is done. You probably have great ideas for how you could do it better. Why don't you figure those out, test them, and then we'll implement them. So the idea is, this is really powerful because in an ideal state, we'd have all 5,000 Virginia Mason employees working to improve their work every day, as opposed to 30 people in the quality department. Think of how much more work you could get done. So what's the result of this? Patients like it. They get safer care. It's higher quality, and it's more timely. They're not waiting days to see their primary care provider. We have same-day access. They're not waiting for lab results. Those are turned around pretty quickly. Decisions can be made. And they get to spend a lot more quality time with their nurses, physical therapists, providers, because things work well. Providers like it because they spend more time talking with patients, listening to them, and treating them, because their work becomes more efficient. And the system likes it because we cut healthcare costs. I'm sure you guys have heard that number that something like 30% of healthcare is just total waste. Total waste. Well, that's where we're going. I actually think it's probably more. It's probably an underestimate, but that's what we're going after, the waste. Now, everyone says when they hear about, oh, Toyota, Why are you taking something from them? People aren't cars. You can't make this work in healthcare. They're complex. But if you think about it, the way that we're kind of processing patients, we're delivering care to them, it's not that far off from manufacturing. Quality is absolutely essential. They're very intricate, complicated processes. There's unpredictability. There's a need to keep costs low, and there is waste. We're actually not that far off. The other thing I really like about this is it provides a very scientific method for improving care. And I think this really resonates with us who kind of have a science background, a science mindset, right? If you want to understand something, you got to understand the process. You got to go and measure it, so you get actual real data. Through those two, you identify improvement opportunities, you test change, and you remeasure. And then the part I like about this is it's cyclical. You're not done. You've just gotten to better. And then you want to get to the next level. So it's kind of an iterative process. Why is this important? Well, people trust this process because it's rigorous, deliberate, and data-driven, rather than arbitrary. So rather than someone just saying, we're going to shut down the family practice residency, there's data, there's a process, and you can trust it. This trust drives adoption. So healthcare providers, especially physicians, are the hardest to convince to change anything. But I can tell you, if you show them the data, if you show them over and over again that this works, they're more likely to accept it and to change, because they know that it's going to improve their work and their life. All right, so I'm going to talk about a quick case, and this is near and dear to my heart because I'm a budding primary care physician, which is quite rare, I think, coming out of this program, but hopefully not forever. And I'm going to talk a little bit about how we can improve flow in primary care. So just imagine, this is the life. I know a lot of you haven't been in your clinics yet, so you might not have a sense of a life of a primary care provider. But there's a lot of things coming at them. A lot of, in addition, patient visits, that's one of them. So they're seeing patients, but other things are coming at them at the same time. There's test results that they ordered a couple days ago. There's phone calls from patients and family, outside records coming in. There's a lot to process, and the problem is there's not enough time to really do all this work. So the results of this are, person comes in for foot pain, you're not going to look at their health care records. You don't have any time. They might be 5 years overdue for their colonoscopy, but I can't deal with that right now. You're running late to visits. You're staying late to finish documentation, and you're missing test results. Makes you think, is this what I went to medical school for? To be overworked, to feel like I'm not delivering the appropriate care to my patients, and to always be running late, always apologizing for why I can't get into the exam room on time. So how do we fix this process? This is a busy slide. All I want you to get is, the first thing they did was go and observe where the providers are. They're the little red ones. They're kind of going back and forth all day. And the thing that's interesting about this is that you see this green line. It's kind of building all day. This is all the work that they have to get done before the end of the day. These are all those test results, the phone calls, the messages they have to return. They don't have any time to do that during the day because they're just running from patient room to patient room. And that builds up, and they're staying 2 hours late to finish that. Then we go and measure. Again, don't get into the details here. This is measuring the medical assistant, how they spend their time. The only thing interesting to note here is that they're spending 12 minutes out of 22 minutes, more than half of the time idle. They're not doing anything. You may have seen this before. This is a value stream map. All of our improvement efforts start with, after doing the measurements, after doing observing, is building a map of what the process is. The important things to see here are not any of the details or any of the numbers or anything, but that we're looking at this from this perspective of the patient because we want to improve the experience for the patient. And this provides kind of a shared framework from which we do our improvement events. So everyone can look at this and say, oh, I can see what the process is. I can see where the areas of improvement are. Opportunities for improvement. So this is what they found from going and taking a stopwatch and seeing how long the medical assistant was taking, how long the provider was taking. It's called a percent load chart. They're saying that the MA is active about that much of the time, and the provider is spending a lot more time working. And that red line, it's not really important to understand what it means, except that that's the rate at which work is coming. That's the rate at which patients are coming at you. So if you're above that line, that means you're running behind. That means you're spending more time than you have doing your work. So you're always running behind, and you're always staying late afterwards to finish up things that you couldn't do during the day. So out of all the things that they've observed, they found all these different opportunities. They found there were mistakes in medications, patients were waiting a lot in the office and for results, there was neglected healthcare maintenance, people, morale was low, people were burned out. The one I'm going to focus on is this one, non-physician work done by physicians. So what they found is that the medical assistants were doing relatively few tasks when they were actually capable of doing a lot more things that the provider was doing. So keeping up the problem list up to date, doing the healthcare maintenance, medication list, allergies. So they decided to shift that work over to the medical assistant, who's perfectly capable of doing that. This is my favorite one. This embeds evidence-based medicine, standard work, and setup, kind of all in one thing. So a lot of times primary care physicians see complaints that are very common and have a standard way to evaluate and treat them. So this was for the example, back pain. So what we've done is we've created these templates where you basically have all of the questions you need to ask for someone who comes in with a back pain complaint. All of the red flags, the things that you need to ask to make sure something more dangerous or systematic or serious isn't going on, like cancer or some kind of infection. You have the physical exam, the assessment and plan. It's all already in the note. The medical assistant will bring up this note, start at the provider's name, and actually ask the history of present illness for the patient. So they'll ask, where's the pain? On a scale from 1 to 10, how bad is the pain? All those OPQRST things you guys learned, they'll ask all the red flags. So when the provider comes in the room, a lot of the work has been done already. That kind of work, I mean, those questions are pretty standard. You can't really, you don't necessarily need a medical degree to fill out that form and to understand. They can come in, ask some more clarifying questions, do a physical exam, and have the rest of the time to talk with the patient about what are we going to do about this? Why is an MRI not indicated for you? Well, fortunately, I've got all the indications right here on my note. You know, you've had disabling symptoms for more than 6 weeks, et cetera, et cetera. You know, you don't fit any of these. Imaging wouldn't help us. So you actually have evidence-based recommendations right there in front of you, and you can provide the best care every time without having to keep it all in your head. It's great. And what they found is that this way of documentation takes very little time. So providers don't have to do dictation at the end of the day, dictate the note. They just fill out a couple more things and then sign the note and they're done. Really reduces time. And it's great. Another thing they've gotten the medical assistants to do was reduce setup time. So basically, the medical assistant will come in and kind of troubleshoot anything that can be done before the provider gets in the room, they'll do. So this is an example of a shave biopsy kit. So instead of the provider coming in the room, have to look for all the things, get them all ready, do the procedure, the medical assistant will have this all set up for them. Sorry. They'll have this all set up for them ahead of time so that when they get in the room, they can just spend time talking to the patient, doing the procedure. Same thing for PHQ-9 forms, which are screening kind of quantification of depressive symptoms for someone you're following with depression. All that stuff will be done before the provider even gets in the room. And then the provider and the MA will actually plan in a daily huddle all the things that need to get done for their patients before they get in. So this is really also a time saver. And then, one of the things we did, I think a lot of the electronic medical records have this now, but we built this like 10 years ago, was a healthcare maintenance module. So basically, anything that your patient needs will pop up as being due. So you can see this person needs to have their breast cancer screening. So the medical assistant will actually go and look at all of the things that need to be done, and we'll talk with the patient and try to set them up for appointments. So it's, and start the conversation. So it's not left up to the provider to remember that at the end of the day. That actually gets done every time. So what are the results? So they saw that before they kind of implemented some of these changes. We talked about the providers spending a lot more time, MAs not being used most of the time. They actually were able to level load the work, and you can see the provider's now below the tech time, meaning that they're actually running on time, on schedule. They've got time. They may even have time in between patients to finish some of those, to look at some of those test results, to call their patients back, to get some of that other work done so they're not there late, finishing documentation, doing all those things. That's really great. And even beyond this, we've been going to, this is great for this talk, talking about going into multidisciplinary teams, talking about using people for their appropriate skill level. So we're kind of moving away from doing the provider, MD, patient dyad, and now kind of looking at kind of multidisciplinary approach with skills aligned with the tasks that are needed. So we've got the medical assistant. I kind of talked about their work already. We've been using nurses a lot, actually, in primary care to do diabetes management, chronic disease management. I mean, a lot of it's very algorithmic, and a good diabetes nurse can do a better job than a primary care provider, because that's what they do all the time. They're fantastic. And they talk to the patient. They provide a lot of education. They kind of troubleshoot, why are we struggling with your glycemic control and stuff. And then the provider will come in at kind of the end of the visit and offer any other medical advice. But often it's just me saying, yeah, that's great. That's great. I'm glad you talked about all those things. That sounds like a great plan. We've been using our pharmacist also a lot more. I don't see any pharmacists here in the room. But especially for people with resistant hypertension who need to be on multiple medications. We've also been using them to call patients after starting antidepressants to ask them about side effects, see how things are going, to try and improve adherence to those things. And then you've got the provider acting more as kind of a mentor and coach to everyone in doing diagnosis and treatment of new problems and overseeing complex things. So you've got everyone kind of more aligned to what they actually went into their chosen profession for, kind of using everyone to their highest level. What are some of the results? I won't go through these, but improved efficiency. Staff morale improved. The medical assistants I've talked to have loved this. They are extremely, they're amazing. They troubleshoot more than anyone I know. They're always problem solving, how can we get things done better for the patient? They're very active and very engaged. A lot of them are really engaged in our quality improvement work, and are actually going through some of our quality improvement curriculum. And often they go on to be managers or go on to get more advanced degrees. So it's been a really great experience for them. And then the providers get to spend more time, actually talking to patients, engaging in shared decision making, and using the skills that they went to medical school for to diagnose and treat patients. So it's kind of great for both people. This is just showing that our rates of health maintenance, having all their people's health maintenance complete, kind of went from 50 to 80% in 2 years. And then this is important. We went from losing money on primary care, we used to be a cost center, to actually making money on primary care, which is important for being able to reinvest into the practice and improve patients' care, hire more diabetes educators or social workers or things to get things done better for our patients. So it's financially viable. Okay, so you might be thinking that's great for primary care. What does this mean for me? So I'm talking a little bit about what we've done to improve our nursing. Are there any nurses in the room today? Wow, fabulous. I'm so excited to share this with you because I think this is great. And I've had a lot of really, really good interactions with interactions with our nurses, and I found that it's really easy to find them because they're often at the bedside. And they really know my patients well and are great partners in helping me deliver the best care to my patients. So I'm really glad that you guys are all here and interested in this stuff. Oops. So we did the same thing. We looked at, what are issues with nursing? Where are they spending their time? They found that the nurses that they looked at, they only spent a third of their time at the bedside. The rest of the time was spent for searching for supplies, retrieving meds, and handoff, documenting. And they found that there were constant interruptions in their work, and they were leaving documentation for the end of the shift. So documentation wasn't available in real time for other members of the care team to look at. So they did a couple of things. First they saw, well, they have all these patients, but they're in a line, and one patient's way down the hall, another patient's up here. There's just a lot of back and forth. So they scrapped that and said, we're going to move to geographic cells. So imagine you're standing in the middle, and you have 2 rooms on each side. So your patients are all kind of surrounding you. It reduces the distance that it takes to walk, and you can kind of have like a line of sight. You can kind of see into all the rooms, and you can be right there pretty much immediately available. That was pretty easy to change. Another thing they saw was that nurses were doing their shift handoff in a conference room, away from patients. A couple issues with this. It took about 45 minutes, an hour to do the handoff. Nurses were an hour into their shift and hadn't seen a single patient yet, and no one had been taking care of the patients in the meantime. So all these issues built up over the hour, and they were playing their first couple of hours were just spent catching up and actually seeing all the patients. So they decided to move handoff to the bedside. And what this did actually worked pretty well. They used more structured communication because it was in front of the patient. The nurses got to see all of their patients within the first half hour of their shift. So they'd already seen everyone and were able to address any problems right then. So they had a good start to their shift because they already knew what every patient, what their baseline was, kind of what the plan of care was for every patient. And patients liked it because they got a chance to participate and communicate their needs. Family members also liked it because they could be available to help, tell the nurse, oh, my mother with dementia, the last time you gave her that pain medication, she just got delirious. Please don't do that. So to bring up issues that they might not otherwise have had. So that was helpful. And then they did this analysis and they showed what are nurses going to look for? What supplies do they need? They found oftentimes it was one of 7 things. 7 things that they were leaving the bedside to go search for. So what they did is said, hey, let's just put those in a kit, put them right at the bedside. Every patient has these 7 supplies at the bedside. So the time spent looking for those supplies dramatically decreased, and they're available at the point of care. And they're refreshed by non-nursing staff, so non-clinical staff are constantly refreshing them. So you're not wasting a nurse who's very well educated, valuable time going to search for supplies. What we also did is every nurse now has a computer on wheels, so they take it into the rooms and actually document things as they're happening at bedside. So every medication ordered, hung, every antibiotic hung, every temperature taken gets documented in real time, and that's available to the other members of the care team. So me as a resident, I can look. Okay, I ordered antibiotics on this septic patient like half an hour ago. Has it been done yet? And I can look and I can see in the administration record. Oh yeah, that was given. Okay, great. My patient's getting the appropriate care. Oh, I can see their temperature in real time. I can see all these things. It's really helpful to have it done in real time instead of at the end of the shift, which was what was happening before. And then this is a really interesting one that I really didn't even know about until I started reading about it. So they changed the way they were doing things and said implemented hourly rounding. I don't know, do you guys have that here? Do you know what that, has anyone heard of this? You do? Yeah? Yeah. So again, this was a while ago, so I think a lot of places are doing this now, which is great. But what's your experience been with it?
So I actually used to work at a medical center, so I'm very familiar with the but I was a nursing assistant, so I really liked it because I got to meet go to my patients every hour just to check to say hi, even if what's wrong. It was just a good contract.
Yeah. Anyone else have that experience with this? Yeah? Anyone? It's good? Okay.
I don't know what to say about it, so I making sure that they needed rather than say, hey, we can fix it for you, but
Exactly. So the idea of this is that a call light represents a defect. So instead of the call light being the impetus to go see the patient, it means that you didn't appropriately anticipate their needs. That's kind of the idea. So the idea is that you anticipate things before they happen. So because a lot of patients, they won't call until something's like an emergency. They're like, I have to go to the bathroom right now. You have to get me out of bed right now. And that's difficult to deal with because maybe you have another patient that you have to, you're in the middle of something with and you can't deal with it right now. So this is a really nice system. It kind of starts out with asking, are you comfortable? Which is better than asking, how are you doing, apparently, because people will just say fine, but if you say, are you comfortable, it elicits all sorts of complaints, as you can imagine. And like you said, there's kind of a standardized checklist of things that you ask them. Do you need to go to the bathroom? Do you have everything you need in place? And you're supposed to make sure you arrange everything kind of in place so they don't have to get up and they're not going to trip and fall. And so the idea is really just to be proactive. And I can tell you as a provider, I've seen the results of this because I remember going into a room here when I was a medical student, and every time I went in the room, they had something that needed to be done. And like something that needed a nurse, or a patient care technician, or someone right then to like make it happen. And I could never find the nurse. Maybe it's different now. I hope it's different now. But I don't have that happen to me very often. Like I go into the room and they say, oh yeah, they're taking care of me so great, and everything's fine. And sometimes I have to go to the bathroom in the middle of my history and physical, but it's also very easy for me to find the appropriate person to help. So this has been great. So they found basically they increased time spent at the bedtime from 30% to 90% by doing all of these things, and then also reduced falls and length of stay. And I can say anecdotally, I don't have any data on this, but I can say that patients that I've encountered are very satisfied with the care that they've gotten. And as a provider, it's good for me to know that my patients are being well taken care of, right? Because I have no actual ability to administer medication to a patient. Think about that. You can't actually give them the antibiotics that they need. You can't actually give them, anything that they need. So it's really important that nursing care is good. So thank you all for being here and being good nurses. All right, I'm going to try not to bore you too much about this. I'm just going to talk a little bit about our curriculum. One of the cool things I think about Virginia Mason is that they require everyone who's in any kind of leadership or management position to go through this curriculum called the MPS for Leaders. And really it teaches you the nuts and bolts of quality improvement and makes you go through all of it kind of in your own sphere of influence. So, you have to identify all the types of waste, and you have to, figure out, how to help someone implement an idea. You have to, measure a process and actually run an event to try to improve that process. So what it really means is that everyone in the organization is really familiar with these techniques and tools and are actively using it to improve the work that they do. And this is also an option for our residents. Two of our residents who are now chiefs have actually put themselves through this curriculum. It's optional, and run improvement events based on that. And that's kind of what I'm in the midst of this year. So it's fun. And actually, so I kind of primed you about the email communication. So one of our residents who's now a chief did a project on helping streamline communication to residents. And we were getting 12 emails a day, 12 emails every single day that we had to look through and filter and say what's important, what's not important. And about 50% of messages were not read at all. And the ones that were, it took about 3 days for someone to read the message. So if you can imagine you're trying to communicate anything important to residents through email, you don't know. You hit about half of them, maybe, and they might see it in 3 days. What if it's something that needs to happen right now? There was just no way. So one of our chiefs did a project on trying to kind of sort and streamline the communication, and they created this Tuesday soup. So it's basically a digest that we get every Tuesday. So reduce our emails from 12 emails a day to 1 to maybe 3 per week, because almost everything goes in here. If it's not urgent, it goes in here. There's a couple of other emails we get each week, but this is mostly it. And when you get this email, you have to read every single thing that's in here. Well, this goes out to all the residents, so you don't have to read the anesthesia and pain medicine fellow bit if you're a medicine resident, but you have to read all these things. And you can see things are prioritized. There's no FYI in here, but they have FYI, must read, and dates are very obvious. Please act on this. So, and they also kind of sorted what was necessary from unnecessary, so we just don't even get unnecessary communications anymore. because of this system. They have a system for prioritizing things and getting them all in a nice little digest. So I can tell you this has improved my life significantly. And they went from, let's say, 50% of messages being read to 100% being read. So they use read receipts to measure this. So every email is being read. And from the lead time is like from 3 days to a message being read to like 5 hours or something. So people are reading them, and they're reading them pretty quickly, hopefully getting the information. That's the part that's hard to measure. So that's great. Quality improvement can be very simple and low tech. This was our admission phone. So every team, every resident gets a phone, a little cell phone, and they all used to be in a pile, and you just kind of had to find which one yours was. So when someone came up with the idea of using one of those shoe organizers to organize where every phone was going to go, and it looks really silly and it's really low tech, but it actually works quite well. You can see, intern A, team A, resident, phone goes there with the charger. It's quite nice. So I think this doesn't have to be rocket science for it to work. One of our residents is very interested in the EMR. I think he actually did a master's in informatics. So he was frustrated by, we call consultants all the time, right? So we'd find out who's on for infectious disease and find out who to page. And the process for doing this was something like 3 scroll bars and like 11 clicks. It was kind of ridiculous. So he actually created his own kind of streamlined page, and it's now 3 clicks. So we're still testing that out, actually, and if we can measure improvements and work, they're actually going to implement this into the real website. This is just his little trial, and he's got a little box for feedback. I like that. Oops. This is another thing that came out from a resident. Resident participated in one of our big rapid process improvement projects, workshops, which is a week-long quality improvement event. He participated in it. This was about trying to deal with all the demand in the lab. So every morning there's a ton of lab samples the lab has to process. They're trying to figure out how they can kind of reduce that and smooth that out a little bit. But he noticed that when he was on nights, he would always get paged by the nurse saying, "There's no morning labs ordered for this patient. Do you want morning labs?" And the problem was, it's impossible to tell whether the team meant for that to happen or whether they forgot to order them. So what we've been trying to do is reduce just reflexively ordering morning labs. Like if you don't need them, don't order them. But the problem was there was no way to communicate this to anyone. So they would end up getting ordered anyway by the night intern. And so we had a lot of wasted labs. So he came up with the idea of putting a AM lab holiday order. And so that can be communicated to everyone. So you'd be directly choosing not to order labs to reduce the amount of labs that are ordered in the morning. It actually worked quite well. And then everyone is probably experiencing issues on both sides, from nursing and from providers of paging. It's like a 1990s technology that we're still using. And if you ever experienced getting paged, it's a pretty miserable experience, right? You have this thing that you have to wear, and it zaps you every time that somebody wants your attention. And you get almost this Pavlovian response. Like, you are so angry every single time that you get a page that it's just, you don't even care, like, if the page is meaningful or, like, it was necessary. Like, you're just angry at the person who paged you. You're so mad. And the thing is, it also interrupts, like, your workflow. So you might be talking to a family about end-of-life care, and all of a sudden you get a page about this patient needs a bowel regimen, right? But you have to look at it because you don't know what it is until you looked at it. It could be, this patient's SAD is in the 80s, and can you please come assess? Like, there was no way to differentiate between what needed response now and what didn't need response. So one of the residents had an idea of using there's a messaging function within Cerner to message people. Anyone who has access to Cerner, which is our medical record, can message each other. So the idea of having nurses and other providers message the docs instead of page. So you get a message in your Cerner, comes up in your Cerner inbox. You put on a little notification, just like you would have for your email, right? When that little number comes up, so that you know you've got something, but you don't have to respond to it right away, and it doesn't physically buzz. So if you're in the middle of something and you're not at your computer, it's fine. You're not gonna be interrupted, and you can actually, instead of having to like look at it and find the phone number and call, and then the nurse has to like come to the phone and talk with you, you can actually send a message back. So it's kind of two-way communication. And you can say, I'm on it, or I ordered it, or give them some kind of feedback that you've received the message and you are working on it, so that they don't page you again or message you again saying, why haven't you responded to this? And anecdotally, this has worked great so far. People are pretty happy with it. There's been some issues with, like missing messages and stuff, but we try to save the pages for the really urgent stuff that needs your immediate attention. And it's really helped improve our workflow, kind of quality of life. So I just wanted to close out, and then I'll let you guys ask any questions on what do our residents have to say about this system. To their chief resident, quality improvement is part of the fabric of our daily lives. The quality of culture is seeped into our mindset. So I talked about a bunch of tools, but what you really get is that people just start thinking about things differently. They start thinking about everything in terms of how can this be better, instead of how is this the way it is. This is a good one. Teaches you to look at problems and realize that things don't have to be the way they've always been. This is my favorite. Wacky Japanese innovation techniques, but really a group of people interested in doing things a bit differently. This is our resident IT guy. He's great. So things I want you to get away from this. The MPS provides a system for continuously improving our work. It asks all of you to do the improvements. You reduce waste, which frees up your time to spend in valuable patient care activities. And this is the one I like the best. It's part of our work, not separate from it. It's not someone in the quality department is looking at you and figuring out how you can do your work better. It's you figuring out how you can do your work better. And ultimately, you're going to be the best one at it. If you want to know more, there's this wonderful book. It's very Pines. It's very kind of whitewashed and makes you think everything is wonderful, but it has a lot of good stuff in it. All right. I know that was a lot. I'm sorry. Questions?
Yeah, so the graduates of the residency program, do a lot of them stay at Virginia Mason, or do they go elsewhere? Do you worry about not making an environment where the culture is continuous process improvement?
Yeah, so that's a good, I think someone asked me that earlier today. I think, so a lot of people do stay at Virginia Mason, but people do also go elsewhere. I think it would be tough. Although, I will say a lot of our graduates, especially ones who've gone on to fellowships, have ended up, the places they've gone to have looked to them to be kind of a quality improvement leader. For example, we had a guy who did his critical care fellowship at MGH, and ended up doing a lot of the quality improvement for them. He did end up coming back to work at Virginia Mason though. So yeah, that's a good question. I think it wouldn't be so bad if you were going someplace that was interested in using your expertise to try to help, but if you were going back to someplace where they weren't really interested in quality improvement, it would be pretty tough. But there's a lot of places that run fairly well. Yeah.
I don't know if everybody got a chance to read the article. Would you be able to give a brief rundown of what it was about Toyota that made them work so well, and what that brought to Virginia Mason?
Yeah. That's tough. So Toyota's been using this system and making pretty high quality cars for about 50 years. So they've had a lot of time to really figure out how to do things efficiently. I actually really struggled in this talk to figure out how to break that down into really simple concepts, because it's not so simple. A lot of it is, I mean, the story behind it is, one of the presidents of Virginia Mason, they were losing money. One of the presidents was like sitting next to a guy on the plane who helped Boeing implement these principles at Boeing, and was talking about how successful it is. So he was, we were kind of by chance talking with other people who were doing this in other industries and seeing a lot of success, and that's kind of how it came about. And we had a whole it was kind of the whole board and the CEO decided we're going to go in this direction, we're going to try it. They all took a bunch of people to Toyota to actually see the principles in action, and that kind of sold a lot of people. But in terms of how it works, I don't know if I can give a good, concise spiel. Yeah. Yeah. That's a good question. I don't think that they were paid anymore. Yeah. I would say that it's pretty difficult. It's now a pretty difficult job, and it's very competitive. Like they're very selective about who they choose to be the medical assistants. But I will say the ones that I have worked with are fantastic, and they kind of want increased responsibility. I would say the way that they are compensated for it in some way is that they get a lot of new skills that actually often lead them to pursuing higher, more advanced degrees and getting into leadership positions. But I don't think they're financially compensated for the amount of work. But I also will say, when some of that work is shifted to the medical assistant, their provider's not staying as late, the medical assistant's also not staying as late. So when the provider was there running late, running behind with their patients, the medical assistant still had to be there too. So there are some benefits that way. But yeah, I don't think they were paid anymore. Yeah?
Hi, I have a question about implementation.
Uh-huh.
So when we're talking about giving the MA more complex roles and like doing more for
Uh-huh.
doctors, who's teaching them to do those things? And who's overlooking that the work is correct? Would we just be adding more workload for nurses? Would there be an outside group teaching MAs and nurses work?
Yeah, like how do they get trained? So my impression, and I don't know the specifics about like exactly how the MA training works, but I know that MAs who are trained will train other MAs. They've also done more than even I talked about. Like the MAs are now answering the phones. They do a lot more than I've even talked about here. But I know that they have medical assistants train other medical assistants, and I think that they're all, it's not. I don't think they're hiring more people, but they're getting people who are, they kind of get them to experiment and see what they can do, and then train other people. But I don't know for sure. Yeah. Yeah.
Do you have statistics on the increased time spent with patients?
Let me see if I have anything in our. I might have taken. I didn't even get into rounding. I spared you guys of like all these extra slides that I have. See all these fun things. Oh no, I don't think I have it. Oh, sorry. I do know that they. Sorry, it was about the amount of time that they spend. I know that they have measured all of this. So they have. I mean, they said they. I don't know. I don't have the numbers off the top of my head. Sorry, but I know that they did measure it. And also, it wasn't just more the increased time. It was how you spent your time and how they saw like the value of that time added. So I think actually for a lot of these, like the providers ended up spending less time in the room, but the time that they did spend was more centered around, discussing the treatment options, et cetera, and less centered around just kind of gathering history and setting up for procedures and things. I don't have that data with me right now. Yeah.
Independently for providers and nurses and MAs, this helps with efficacy. But in terms of like patient-centered care and SLIM for what we're going to be practicing, how is this collaborating with each other for the patient's benefit? Like it still seems like we're still kind of independent from each other. And I kind of was under the impression that SLIM was going to help us
Integrate care.
together.
So I will say, from the patient's perspective, I'm going to try to answer your question, although I'm not sure I'm going to succeed. I would say from the patient's perspective, the way that the patient experiences better care is that things are very efficient, meaning that they're not spending a lot of time waiting. The time that they do have with the provider is really high quality, and that they spend some value-added time with the medical assistants actually providing a lot of value by getting their health maintenance stuff done. I would say like working with I see this more working with like the nurses and the pharmacists. So like I mentioned in our care of like chronic disease with the diabetic patients, I would say the nurse and the physician actually really work together to come up with a plan and help people manage their diabetes. So the nurses can spend a little bit more time on education, on troubleshooting, say, okay, well, what is in your diet that's shooting your blood sugar up at this time of day, or et cetera, et cetera. And then the physician kind of works with the nurse to provide a little bit expertise in medication management. And so I say that like they would work together to take care of the patient. The patient sees the benefit. They get to spend a lot of time with the nurse, a lot of one-on-one time, kind of troubleshooting things that are going on in their lives. But they also get the interaction with the provider, kind of helping with their skills and the medication management. Does that somewhat answer your question or not really? Kind of.
It still comes down to more interaction amongst each other before and after seeing the patient.
Yeah.
We'll spend time with the patient, but you guys are just reading the notes that we put in, and then you're going, that must be correct content. And if I just would like to see more of us communicating and getting on the same level
Okay.
in terms of the patient care. But yes, I do understand 100% how the patient care is beneficial and that they're aligned.
So maybe I could give you an example from inpatient care. Are you a nursing student or
Yeah.
student? Okay. So I would say my interactions, I have very rich interactions with the nurses. So when I was an intern, we do rounds a little bit differently, but oftentimes I'm standing at the bedside, I'm like doing my note kind of outside the patient's room. I talk to the patient, and the nurse, at some point during that interaction, the nurse always finds me there, right? And they say, okay, doc, what's the plan of care for today? And I have a very rich discussion with that nurse. This is what we're thinking. This is what we're doing. And I didn't really talk about this in this presentation, but I actually think we have great interactions with the nurses because they spend more time at the bedside and we spend more time at the bedside. So the chances that we're going to see each other, that we're going to be able to talk about the plan of care are even greater. Our ideal would be to have the patient there when we do rounds, not the patient, the nurse there when we do rounds. That's difficult from a nursing perspective because they're often busy doing things and we can't time exactly when we're going to be there, et cetera. But if the nurse is available, often they participate in rounds. And in the critical care unit, we have multidisciplinary rounds. We have a nurse, a pharmacist, and a team, and we all round on the patients together. So the nurse will say their spiel, his or her spiel on what's the update of the patient. They have a whole checklist of things that they talk about. Respiratory therapy will talk if it's an intubated patient. Pharmacy will give their input. It's actually very structured. So we have pretty good communication between the different providers. Does that maybe more get to?
I know that for inpatient, what I see doing, ideally what would be really interesting would be to see when you're doing rounds and we're doing it simultaneously. Where at least so that the patient's there, when I interrupt them multiple times for certain things, or they're answering the same questions twice, and that we're all aligned on the same page.
Yeah.
I know you're absolutely right.
Yeah, and I can tell you that I will often go and I'll go to see a patient. I'll see the patient's nurse. And I'll be like, so how are they doing? And they can tell me exactly what's been going on, and that's really valuable information to me. And I do that for me, and I do that all the time. I love, and our nurses are so great, very on top of things. They know exactly what's going on. I mean, I ask them, so what do you think is going on? You've been seeing the patient for your whole shift. This is the first time I'm seeing them today. What's going on? And often I get a lot of great input from the nurses, so we do try to do that.
Now that you've implemented this two-way communication system, you're talking about paging. How often do you find that you're still paged as a resident or as an intern?
Yeah. So I would say that we're paged a lot less frequently. I mean, normally you get maybe 10, at least 10 or 12 a day. And after doing this, I'd get maybe 1 or 2. And sometimes they'd be inappropriate, meaning that they could wait and they paged me earlier. But I was one of the early adopters, so I loved the messaging. I was all on board. Some of my co-residents were like, no, I want to be paged for everything. What if I miss something? But I actually, anecdotally for me, I did find that it reduced the volume of pages that I got, and that I was able to give two-way communication. If it's something quick, like can you order bowel meds or something, I can just send the thing, okay, done, did it, thank you for letting me know. It's it can be a lot more collegial that way too, and it just feels like, and maybe you won't feel like you're interrupting the provider as much if you're just sending a message or